Good afternoon, everybody. Welcome to our webinar. So this webinar is organized by a project with the Chorus project, and it's on strategic purchasing of healthcare from private sector. And we are delighted to have Mark Hellowell from University of Edinburgh. And he will be discussing mostly the findings from the recent WHO report on private sector healthcare purchasing, particularly in East European context, I suppose. And the reason, and also like we wanted to kind of hear from him because to know more about the experience he can share with us. And then because a lot of policy reforms are thinking about not in exactly, there are different way we talk about the strategic purchasing, but certainly with the public partners to the private sector providing how to buy for the healthcare for the private sector, or letting the private sector to getting involved and provide services, but with some kind of contracts with the government as well. So, without taking, I would like to just kind of pass on to Mark to start, and then over to you, Mark. Yeah.
Great, thanks, Zahid. So I guess I'll share my screen.
Yeah.
Just one second. Can I do that though? Let's see. Sorry, just bear with me.
Yeah, it's
I
coming
suspect
up.
you're now seeing like a really cluttered
Yeah, it's
desktop.
your desktop. Yeah, it's
Yeah,
like
so let me see if I can.
okay.
Uh,
Yeah, it's there.
that
It's
might be a bit
yeah.
better. Give me 1 second. So my eyes have really deteriorated in recent months for some reason. My eyesight, I should say. And so
Okay.
I've got this new thing on my computer where everything's like magnified, but the downside of that is sometimes I can't see everything I can see.
Okay.
So just give me 1 second. See if I can figure this out. Right. Hopefully that's a bit better. Right. Okay, so thank you, Zahid, for your introduction. So I'm Mark Hellowell. I'm from the University of Edinburgh. Although the work I'm going to present this morning or this afternoon, depending on where you are in the world, is work I did in partnership with the WHO European Office, and I should say that that is relevant in the sense that the work is really based on empirical experience, both in terms of documented evidence, but also direct experience of working with countries in Europe, which is defined in that strange WHO way of essentially what we normally think of Europe as well as the Caucasus and Central Asia. But it's a part of the world with a particular sort of set of relatively consistent health system characteristics. Obviously, there's quite a bit of diversity as well, but there are a few common variables which I'll speak to. So it does have a particular, the analysis that I'm about to set out does have a particular context in mind, or a particular set of contexts in mind. And in fact, we were working on the basis of empirical experience in a number of specific countries, so particularly countries that I've worked in over the last few years, so Georgia, Ukraine, Uzbekistan, and a number of others. So often post-Soviet countries or post-socialist countries. And so countries that have a similar legacy in terms of the structure of the healthcare system, albeit there have been diverse reform processes compared Georgia, say, to Uzbekistan. It's very, very different where they've ended up in relation to the role of the private sector, but a fairly common heritage. And then a number of other things which are probably relevant as well, which are held in common. So in particular, sort of demographic variables. So generally speaking, most of these countries are in population decline. So that's something to bear in mind, especially when it comes to thinking through the role of strategic purchasing in shaping the appropriate network. And I suspect this is quite a key point of difference. I know Chorus, you're working in South Asia, you're working in Africa. Generally speaking, you're working in countries that have increasing populations, in some case rapidly increasing populations, and indeed settings in which there's rapid urbanization. And that's quite different to most of the countries in the European region, and that is a relevant thing to record as well. Anyway, I don't want to get too much into the detail of that, but just to point out that this is a piece of work that focuses on the European region, and that is relevant to the shape of the analysis and the focus of the analysis. And I think what might be really interesting in terms of the Q&A or the discussion part of this meeting is when we think about some of the similarities and differences in the setting between this region and the regions that you're working in. And we can perhaps tease out some of the potential implications of that in terms of the analysis, in terms of policy considerations, etc. Okay, Zahid, another thing I should probably just say is that we're focusing here on purchasing from the private sector. Whether we're focusing on strategic purchasing or not, I think is an interesting question. The truth is probably in most environments we have purchasing, and that creates a set of challenges, the solution to which would be more strategic purchasing, right? So the strategic element of the purchasing apparatus is not necessarily there in all cases, but it's something that should be built in order to get better outcomes from purchasing. All right, so let me turn to the presentation. So essentially, I'm summarizing to some degree the findings from this recent report, which we published with the WHO European Office. As I said, we're focusing on essentially the inclusion of the private sector, generally defined, within publicly financed healthcare delivery networks. So by publicly financed, we include both the use of general government revenues to purchase services from the private sector. In other cases, the purchasing takes place by social insurance agencies. We're open to both of those possibilities. Here, we're looking at the use of public funds to purchase private sector capacity on behalf of covered populations, whether those populations are covered through general government revenues or SHI. We're particularly talking about service delivery, so we're not primarily interested, or indeed it is without our scope, areas like pharmaceutical purchasing, the pharmacy sector, etc., medical devices procurement. That's all outside of our scope here. We're focusing particularly on health service delivery, so private healthcare providers. Our starting point is that there might be a variety of different reasons why governments or other health agencies might want to include the private sector in their service delivery networks. And, there are fairly sort of generic lists of reasons why you might do that. And again, this is one of those areas that's likely to differ between different countries and regions of the world. But particularly in Europe, it is generally the case that governments might want to do this in order to harness the perceived disciplines of private ownership and management, to generate, through the inclusion of the private sector, an additional stimulus to choice and competition. So, as many of you will know, across many European countries, there has been an effort over, I guess, the last 30 years to try to increase the amount of patient choice and provider competition within the publicly financed network, even within the public sector. And so, insofar as you believe patient choice and provider competition are good things, and you believe that private ownership and management may drive better performance in terms of innovation in technology, in clinical services, etc., then by including the private sector in publicly financed networks, you might get an additional stimulus to choice and competition, which may generate significant benefits, both from a public policy and a patient perspective. And in addition to that, you may want to look to harness the resources of the private sector through purchasing in order to address capacity gaps that occur in the absence of the private sector. Again, this is one area where context matters, because in many of the countries in which we've been working, so Eastern Europe, Caucasus, Central Asia, the primary means of delivery of state-guaranteed services is the public sector. And the public sector is often very extensive. And in some cases, like Ukraine, for instance, there's significant excess capacity in the public sector. And so, generally speaking, the capacity rationale is less stressed, is less important. But there may even be, in those sorts of contexts, particular service areas or particular geographical areas where there is a lack of capacity, there is unmet need, and potentially purchasing from the private sector is one way of addressing that problem. So we have these three areas of sort of private sector management and the disciplines of that, choice and competition and the additional stimulus that could be presented by the private sector, and addressing capacity gaps, either in general or in specific areas or specific geographies. Obviously, whatever the rationale, when you bring in the private sector into your publicly funded network, then the government loses an element of direct control, of direct power over that relevant part of the network. So that sort of traditional focus on bureaucratic influence and control is diminished, and other things need to step in, other things need to be deployed in order to create the right kind of incentive and accountability environment and to protect patients, to protect the public interest. And the two sort of principal instruments for doing that are regulations and purchasing policies. And when I'm talking about, well, the whole sort of suite of regulations that one might cite here in terms of everything from sort of facility licensing and the enforcement of licensing conditions through to professional regulation, both in terms of the competencies of professionals and the ethical frameworks within which they operate. All of those sorts of things are going to be relevant, but also purchasing policies. So things like eligibility criteria, the extent to which there is selectivity in purchasing, contractual specifications, monitoring mechanisms, all of those things become extremely important. And they become particularly important when we start thinking about the sorts of challenges that we might associate with a non-strategic approach to purchasing from the private sector. So we cover primarily, if you look at the report, please do take a look. It's available on the WHO website. If you look at the report, the analysis is sort of built upon a number of specific empirical experiences, country-level experiences. So, as I mentioned, Georgia, Uzbekistan, Ukraine, Bulgaria, Estonia. And there is some, as I mentioned, a sort of quite a lot of commonality in terms of health system legacies in these countries. But there's quite a bit of diversity as well. So if you think about a country like Uzbekistan, sort of in the post-Soviet era, there was fairly limited change to the structure of the health system. A lot of public financing was removed. There was a sort of economic and fiscal crisis in the 90s, which certainly had huge impacts, huge sort of shift from public financing to out-of-pocket payments. But structurally, the health system didn't change hugely, and the role of the private sector has been quite limited, and so it remains. That's very different to a country like Georgia, where from 2007 onwards there was this huge, pretty wholesale privatization process, such that the overwhelming bulk of the means of healthcare production, if you like, is now in the private sector. So very important to be aware of the fact that while there are these common sort of legacies, there's quite a lot of diversity in how these health systems are structured today. And so what we tried to do in the report is present analyses which are equally applicable across the region, but also leverage the fact that there's a bit of a natural experiment going on. So for instance, in Georgia, where almost all of healthcare delivery is in the private sector, much of that publicly financed, there's a huge amount to learn from that experience that countries like Ukraine and Uzbekistan, which have only begun to dip a toe into these difficult waters, they can learn a lot from those Georgian experiences. And so our objective was to assess the benefits, costs and risks of private sector purchasing from the private sector, and offer some policy guidance on if, when and how to effectively do this. And okay. All right, so I want to split the presentation into two halves. The second of which I think is actually the more interesting, but the first one is a sort of a fairly generic analysis of some of the benefits, risks, costs of purchasing from the private sector, and thinking through what that means for policy. This is in part one. In part two, I want to turn to the issue of the network. And that's certainly very relevant to the European region, and it'd be really interesting to discuss the applicability of these analytical findings to the context in which you're working. So anyway, I'll come back to that. But so we've got this sort of two parts. The first one looks at sort of competition, the nature of competition, some of the benefits and risks associated with how competition plays out in publicly financed networks. In part two, I want to focus on network effects. So how the private sector's inclusion in the publicly financed network might have an impact on the structure of that network and some of the costs and benefits of that, and how policymakers might take action. Okay, so again, this is sort of a fairly generic and familiar analysis of some of the sort of benefits and costs of private sector involvement in publicly financed networks. So governments, as I mentioned, have been quite keen to encourage patient choice and provider competition. And they've done that through a variety of different mechanisms. One of them is to change the nature of health financing, in particular, so that, moving away from global budgets, moving away from paying established facilities for their costs in order to ensure that they can deliver services, but rather moving to more output-based or activity-based payment mechanisms in which money follows the patient. The idea being that then providers have incentives to try and raise quality or become more efficient in order to attract more patients. That can happen within the public sector, what we used to call internal markets. We had those in the UK, for instance, where the public sector entities were competing with one another in order to attract patients and thereby generate more surpluses and sustain their operations. But in addition to that, many countries which have adopted that kind of model have sought to include private providers in those delivery networks. The idea being that this would create a sort of an additional stimulus to choice and competition, giving patients another option in many health economies, and generating a sort of a greater competitive threat, if you like, to incumbent public providers. In addition to that, there is a theory that the private sector in particular may have especially strong incentives to respond to a competitive environment in ways which might lead to better performance. And so the theory is based on the particular nature of the private sector, its operational objectives, how it responds to incentives, how it's held accountable, etc. So clarity of objectives, for instance, that might be something like profit maximization or revenue maximization or sales maximization or something like that. Generally speaking, private sector, especially for-profit organizations, have very powerful incentives to generate surpluses, to remain, to sustain their businesses, to provide their investors with their expected rate of return, etc., etc. And this provides a clarity of objective which is typically missing in many public sector organizations, which have a range of objectives, sometimes implicit, sometimes explicit, but in all cases quite hard to operationalize. There are, within the private sector, especially the for-profit private sector, external pressures on managerial performance. So shareholders, where you're talking about publicly listed companies, publicly limited companies, you have shareholders who provide a strong external pressure on managerial performance. You also have probably creditors, banks or others, that have to safeguard their own rates of return and exert pressure on the business to ensure that it's profitable and it generates cash flow sufficient to be able to repay them, to provide the debt service on these loans. And you also have pretty hard budget constraints, in the sense of, these organizations want to stay in operation, want to stay in business, and their ability to do so is largely determined by their ability to generate sufficient revenues to meet their costs and to provide adequate rates of return for their investors. If they don't do that, then their existence is threatened, and managers have to take steps to avoid that. So this is important. I think when we think about introducing the private sector, it's not just that you have an additional element of competition in the market, but you're also introducing a new type of entity. If you're going, again, in Europe, we're thinking about the default being a largely publicly delivered system. You're bringing in a new kind of organization, which has a different organizational mission and is likely to respond to incentives in a different way. Now, get this right, and that could be beneficial. But if there are incomplete contracts or regulatory gaps and limitations, it can potentially be problematic. So there are some risks there, and many of these risks relate to sort of fairly familiar, I think, to everyone, market failures. Many of these arise from information problems or information asymmetries, all of which means that we can be a little bit less confident that markets in this area in healthcare are going to deliver efficiently in the way that we might expect in other areas of economic activity. Again, a lot of these market failures relate to problems of information. Patients usually don't have sufficient information to be able to make well-informed, effective choices in the market for health services. And this means that a pure market mechanism may not lead to a situation in which, for instance, providers feel like a strong imperative to be efficient and to generate high quality, especially high clinical quality, in order to attract patients. There might well be other ways of attracting those patients that are much less consistent or much less aligned to the goal of quality of care. So we do need to bear in mind that those sort of familiar information asymmetries and the performance challenges they give rise to are also relevant here. Where there are regulatory gaps, where there are limitations in the purchasing apparatus, in other words, the general case, right, where there are always regulatory gaps and there are always incomplete contracts, then there might be other ways in which the private sector can ensure their profitability, other than being profitable by raising quality and attracting more patients. And again, these are probably fairly familiar to many people, sort of quality shading or quality skimping, lowering your own costs of delivery, so to maximize the surplus or profit you can generate from the publicly funded tariff. reducing staff numbers or qualification levels where regulations or purchasing policies are not adequate to prevent that from happening, selecting more profitable patients or selecting more profitable service areas in order again to safeguard your own profitability. These are things that we see empirically, as well as these are things that we would also predict theoretically. These sort of adverse behaviours are certainly not exclusive to private providers. We see them everywhere. But it's precisely because of those specific organizational attributes of private providers, their clarity of objectives, their propensity to profit maximization, the external pressures they face to generate profits, hard budget constraints. Arguably, these create additional, stronger incentives to respond to regulatory gaps or inadequacies in the purchasing apparatus in ways which would enhance profitability but might actually undermine the patient interest or the broader public interest. So these are significant risks which, again, we would sort of predict theoretically, but we also observe them empirically in countries like Georgia, for instance, where private sector provision within the publicly financed network has been around for the last 20 years or so. We do see a number of these problems as being sort of very prominent and key policy challenges which need to be addressed. So take a look at the report to see some of the empirical evidence of that. I won't go into that right now. But one of the things I do want to just briefly touch on is the fact that when we talk about, and this may be, I think, be relevant when you're thinking about this in your own work. When we talk about the private sector, it is not a monolithic entity. There's actually quite a lot of diversity and complexity there within the private sector that we also need to take account of, and it also has a bearing on the types of organizational missions that these entities have and their incentives to behave in different ways. So most obviously there's a distinction between for-profits and non-profits, and I think there's quite a lot of literature about that, especially in countries like the United States, where there's long been a sort of process of transition from non-profit entities delivering services to for-profit entities delivering services. And quite a bit of evidence and quite a lot of concern about that transition and what it means in terms of patients' interests. But here I'm focusing specifically on different types of for-profit entity and whether that has some significance from a policy perspective. So in many countries, when we're talking about the private sector, we're principally talking about relatively small-scale providers. They might be sole proprietor or small partnership entities which are delivering services either on a commercial basis or under contract with the state. But there are also other types of entities as well. So in Georgia, for instance, we do see those sort of small-scale providers, especially in primary care. But when it comes to specialized care, both mono-profile facilities and multi-profile facilities, there's a much bigger role for profit corporate entities and even larger PLCs. And an interesting question is, can we sort of look at that in a bit more of a granular way and try to understand whether there are differences in organizational mission, differences in behavior between these small-scale providers versus bigger corporates, which the bigger corporates often face much more of an imperative based on the fact that they have investors, they have creditors, to behave in a more commercial way, if you like, and have a much stronger emphasis on profit maximization. Now, something else which is happening as well in some countries in Europe, and may well be happening in some of the countries in which you're working, is other types of investors moving into the private healthcare sector, which have an even stronger commercial focus, much more sort of capitalism red in tooth and claw, if you like, with a very strong focus on short-term aggressive profit maximization. This would be the case, for instance, for a private equity-owned private entities that are delivering healthcare. And one can, I think, ask the question about the extent to which businesses owned in that way, or investors that are coming into the healthcare space, whether they have a legitimate role in healthcare at all, and especially in the publicly financed part of the healthcare system. Because it may be that their organizational mission, their incentives are so misaligned with a public interest orientation, or so misaligned with the interest of the patient, that it's going to be very difficult to build a strong enough regulatory or purchasing system to really be able to cope with those entities and ensure the patient interest is protected when those entities are within the network. Anyway, so probably haven't got time to go into too much detail here, but I think it's an interesting issue for us to engage with, that when we talk about the private sector, it's not monolithic. There are differences. There are for-profits, there are non-profits, and within the for-profits too, there are some differences. And I think, especially when we think about how different entities are owned, what sort of investors are involved in those organizations, that can have a real bearing on how they're thinking about, the balance between sort of long-term growth versus a very aggressive short-term profit maximization approach. It's a kind of a new area of research, but I think something that policymakers and researchers need to pay close attention to. Okay, so just to sum up on sort of on this first element of the analysis before we come to the network effects. So we have this problem of information asymmetry. There is typically, facing the patient or indeed facing the state purchaser, an absence or an inadequacy of information about providers' capabilities, conduct and performance. All of this creates the potential for harm. This creates risks. And mitigating those risks is quite challenging in practice. It means building strong regulatory apparatus. It means having proper enforcement. It means having really good purchasing policies in terms of eligibility criteria, contractual specifications, monitoring. All of that's really quite resource intensive and quite difficult to put in place, especially in a developing country context. If you don't have those things in place, it can be quite problematic. I think another thing that's really important is to have proper private sector engagement and reporting into unified health information systems. It should never be the case that private providers are allowed into a publicly financed network without also requiring them to be, registered on and routinely reporting into a unified health information system, which is the same across all sectors, and provides really clear information on service scopes, service volumes, resources, and actual activity. That's a bare minimum. That facilitates monitoring, but the monitoring too is also very, very important to safeguard the patient interest and the public interest when you're doing this. I think it's fair to say that what we actually see in most countries, especially LMICs, is that there are sort of big gaps in regulations. Very often you have a pretty sort of robust regulatory system on paper, but that regulatory system is not really in use. It's not really influencing behavior because it's not properly enforced. So that's something that needs to be addressed. But I think the other point to make here is that is easily said. It's actually really difficult to do it in practice. Typically, state purchasing agencies have relatively limited capacity for example, to undertake monitoring. And so we need to be realistic about that. We need to be realistic about the potential for the state to really invest in strong regulation and regulatory enforcement and put in place really robust purchasing arrangements with strong monitoring that will be sufficient to actually mitigate some of these risks that we would otherwise expect and that we have seen being realised in some of the countries we've been working in. And I think, again, just to come back to this point around different forms of investor ownership, that becomes relevant again. Where you have, for example, private equity ownership, these guys that have a very strong incentive to generate high profits in a very short time horizon, perhaps 3 years to 5 years, they're going to be looking on average for regulatory gaps and gaps in purchasing arrangements that would allow them to generate those very high short-term returns. And you do have to ask some pretty difficult questions as to whether you're ever really going to have a strong enough governance regime to be able to mitigate that risk. Okay, so just to move to this second sort of part of this analysis, which really focuses on issues around capacity, network efficiency, some of the risks to network efficiency and how that might be addressed in practice. So in general, private providers might be included in publicly financed networks in order to boost capacity. As I said, in most European region countries, that wouldn't be generally the case. There's already sufficient capacity. There may, in some cases, be excess capacity, but even in such environments, there might be particular geographical areas or particular service domains where there's a lack of capacity, and you might want to bring the private providers in order to address that so that needs can be met. There are, broadly speaking, two approaches to bringing the private sector in for this purpose. One would be to include all willing qualified providers in state purchasing arrangements. So you just sort of throw open the doors, and like anybody that's willing and meets certain basic requirements can deliver services under contract with the purchasing agency. That's one model used in, for instance, Georgia and Ukraine. Or you can take a more selective approach. This is where I think we get closer towards the sort of strategic purchasing ideal. It can be much more needs-based, for instance, or it can be much more based on a certain subset of providers that have to meet certain criteria in order to be selected. So, for instance, they might have to reach a certain accreditation level or something like that. So you can take a much more selective approach. And indeed, you can even have a selective approach that's based on service contracts which are entered into on the basis of competitive tenders. So a couple of very different models there. Throw open the gates. Anybody that wants to can be part of the state finance network, as long as you meet basic requirements and that you're willing to abide by the terms of a standard contract. Or you can have a much more selective approach, whereby it can be very needs-based, entering into service contracts via competitive tenders, or you're putting in additional criteria around quality of care, for instance. To focus on the first approach in the first instance, but this can also be a set of risks that relate to contracting in general, one potential issue is of fragmentation, or potentially of increasing a pre-existing problem of excess capacity. So where you have fragmentation, you might have a situation where new providers are coming in to a network, for instance, a primary care network. They may be very small scale. They may be coming into a market which is relatively consolidated, but this can lead to some element of fragmentation. We see this in Georgia, for instance, whereby we have a very large number of providers, often monoprofile providers, relative to the funds available. So providers tend to be quite small scale, which means the capacity to realize scale economies is quite limited. Often these small-scale providers are carrying out relatively low volumes of care, especially problematic in areas like surgery, where you want organizations and individual providers to have a lot of experience, so you want relatively high service volumes. But where you have this problem of fragmentation, you can have lots and lots of small-scale providers not realizing economies of scale, so that means problematic from an efficiency point of view. Often undertaking relatively low service volumes, which is problematic from a patient safety and quality of care point of view. Also problematic from a regulatory or purchaser's point of view, in the sense that you have a lot of providers that you need to cover, so high monitoring and inspection costs for health authorities, regulators, and purchasers. So this is something to bear in mind. You can have this problem of fragmentation, creating, undermining to some degree network efficiency, potentially threatening quality of care, and raising transaction costs for the state. In areas like Ukraine, where, for example, in the hospital sector, we have a lot of excess capacity, nonetheless, in principle, private sector providers are allowed to enter the network to deliver acute inpatient care. And there you have this question, well, how do we manage that? Because we have this problem of excess capacity. We're trying to address that by reducing the number of beds, reducing the number of hospitals. But you have more private providers coming in, which is offsetting the effect of these optimization efforts, right? So we saw this in Bulgaria, one of the case studies that we outline in the report, whereby a decade ago or so, there were very strong efforts to optimize the network in the public sector. That led to a reduction in beds and increase in efficiency. But at the same time, the private sector was allowed into the network, and there were relatively limited constraints on its ability to grow and to deliver services, perhaps even deliver services on the basis of supplier-induced demand. And the increase in capacity within the private sector was sufficient to more than offset the rationalization of capacity in the public sector, which obviously has an impact then on the financial sustainability of the network. So we had a problem in Bulgaria, and we can learn from that, and I think also have justified concerns about similar impact in other countries like Ukraine. So in terms of policy considerations, this is something that I think needs to be carefully managed. Again, this is where sort of differences between different countries, different regions come in, because we're primarily dealing in Europe with a situation of, low rates of urbanization within a context of generally diminishing populations, right? So we need to be quite concerned about excess capacity. We need to be thinking about consolidating and concentrating services. So in that context, bringing in the private sector introduces new capacity, which needs to be carefully managed. In South Asia, in parts of Africa, where you've got rapidly increasing populations, that challenge may not be there, or may present in different ways. But it may be that actually having additional capacity is welcome, so long as you can finance that capacity adequately. But I think there's still other things to consider, because you have the private sector coming in. Typically, they're trying to generate higher surpluses, higher profits. That generally correlates with delivering higher service volumes. And if you don't have strategic purchasing, you don't have clear contracts with some sort of management of volume, for instance, you can have this problem of supplier-induced demand. So you've got a lot more care being delivered. The state is having to pay for that. These private providers may be investing in additional capacity in order to deliver more services. And then you have a dynamic which, from the point of view of managing scarce public funds, may be really quite problematic. So you have to manage this very carefully. That means having strong regulations in place in terms of the shape of the network, putting some constraints on capacity, but it also means probably a much more strategic and perhaps more selective approach to purchasing from the private sector. This any willing provider approach, whereby you throw open the gates to any provider that meets basic standards, may not be the right approach where you have an existing network which already has excess capacity. And you may also need to think carefully about the possibility of fragmentation in the network. Unless you get these contracts right, you get the eligibility criteria right, and you get the incentives right. We can perhaps in the discussion talk a bit more about what that means in practice. Okay, so I can't see my timer here, so I don't know how long I've talked, but I suspect I'm probably coming up to time. So we'll just sort of go through briefly these conclusions. So it's important that policymakers, first of all, I think one important point here, which sounds so obvious it's barely worth making, but I think is actually worth making in reality, that policymakers should know why they want to do this, right? So obviously policy can arise out of all sorts of different considerations, right? Some of it may be technical, some of it may be political. The private sector is often politically quite powerful. There are interests within it that can often exert their influence on policies in ways which don't necessarily serve the public interest. All of us know that. That's the situation in every country around the world. And so I think there needs to be like a really clear strategic rationale, a technical rationale for why we would look to include or expand the role of private healthcare providers in the publicly financed network. We need to understand what are the strategic objectives that will be served by that. Is it capacity? Is it choice and competition? Is it private management, the propensity to innovate, to invest in technology? Whatever it is, probably it's a combination of those things. But we need to be clear on that. Because we also need to understand that while there may be benefits here, there may also be risks. And we need to manage those quite carefully. And we can learn from empirical experiences in Europe and probably elsewhere to see what kind of risks can emerge, to anticipate those, and to take steps to try and address them. That means having really strong regulatory apparatus. It means moving from just purchasing to more strategic purchasing. So what does that mean? It means having probably a needs-based element to your purchasing decisions. It means having strong eligibility criteria. We want to attract into the publicly financed system those with the really good quality systems in place to deliver safe, effective care on behalf of covered populations. It means having the ability to write really good contracts which protect the public interest. And it also means having pretty strong monitoring arrangements in place. As I mentioned, that becomes much easier once you've got the private sector actually routinely engaging in and reporting into a health information system. But these are things which purchasers typically don't have, and they need to build these capacities in order to manage these risks effectively. The broader regulatory system needs to be strong as well. I mean, there are other reasons why you would want to build that. You want to have good facility licensing. It doesn't matter whether facilities are in the public system or not, the publicly financed system or not. There should be strong facility licensing. There should be a good professional regulation system. The job of the purchaser becomes much easier if those things are all in place, because you've already created a pretty good incentive accountability regime even before you get into eligibility criteria, contracting specifications, these sorts of things. And I think the other thing is, and I think this is generally less familiar, both in a scholarly context and a policy context, managing these network effects, because there are risks of fragmentation, there are risks of exacerbating a problem of excess capacity, either in general or in particular service domains, and that really needs to be managed effectively through the purchasing mechanism. So, to go back to where we began, we're dealing with purchasing here, but not necessarily strategic purchasing. Typically, I would say there is a lack of strategy in these purchasing decisions. We really need to have that strategic element within purchasing in order to get the best from the private sector and manage the associated risks. And I will leave it there. Thank you very much.
Right. Thank you, Mark. Thank you very much. I think that was really, I mean, I think I remember talking to you about this and the particularly the insight of that and these two different parts you have covered and this area because we kind of, as you mentioned, that this is more from European context, but this has been a situation in many countries, in particularly in our countries where the poorest countries, as that where it's a highly populated and public sector's capacity has not been there. But the condition or the like, concluding remarks, he was suggesting that if you really want to do from purchasing to more strategic purchasing, and even like at the stage of purchasing means like whether it's a it's more of a passive way, let the private sector play their role, and then that's another way, or even whatever they're doing through the public sector, saying that, well, their facilities are there, and then buying and providing the services. So, like, I'll just take some question, but I would, if anybody has any suggestion before I kind of request you to answer some of these things. But if is there anybody to um, kind of I'm just opening the floor. If anybody has any question, please raise your hand if I can see that. But otherwise, just just start asking questions. Yeah, thank you, Mark. I think we have this time for that much. I said we have to kind of, I'm sorry to kind of wind it up, but it's like we have to also leave from the office now. Um, Mark, that was really useful, absolutely useful. And I think some of the suggestion at the end as well that with respect to Brownie's question as well, because people are struggling and we are trying to come to that point and ask the policymakers that what do you really want? Because it's like a lot of huge private sector, but it's about that particularly in city urban areas, and probably we kind to probably start taking of that route and then have a really nice that right contract, the quality involved, what kind of a thing. Probably it's that with the best way. But I hope that we in the future will be able to share with you also what we have been doing and how we really took our approach and now what you think about the guidelines, hopefully keep you updated. But I'm sure that people, thank you very much, everybody, to over attending and ask questions. And also the whole thing is available. The record, and the recording is available, will be available, and also the publication Mark referred to. I think that is also useful for us to really go through and will really help us. So thank you, Mark, once again, Mark, and thanks everybody. And I have to kind of finish it here. Thank you, Mark. We'll be
All
getting in
right.
touch.
Thanks then. Okay.
Thank you.
Thank you.
Bye.
Bye.
Thanks, everyone.